Good evening, everyone. Welcome to tonight's VetCat webinar. We are featuring Dr. Robert Baratt of Salem Valley Veterinary Clinic. Thank you for joining us. As people come into the room, just need to put in some quick housekeeping rules on how this works tonight. For the most part, we will be sending you a copy of this recording within a week of the webinar with notes. It gives us time to answer some questions that we might not be able to answer during the webinar, but we're doing things slightly differently for those that have been on previous webinars. You can chat with panelists and attendees within the chat box that's highlighted in orange. And if you have any questions, particularly that you want Dr. Baratt or Dr. Salmon to answer, please put them in the question and answer tile. It allows us to collect them. And if we can answer those questions during the presentation, Dr. Salmon will attempt to do so. And whatever we can answer, we'll be sure to make sure that we can get answers for you from Dr. Baratt. Just a quick reminder that everything you need regarding the VetCat is available at vetcat.com, and we're always happy to hear from you. Our speaker tonight is Dr. Robert Baratt, and I'm going to have the president of Xoran Technologies, Dr. David Salmon, introduce him. Dr. Salmon.
Thank you, Ramidi. Thank you, Dr. Baratt, for taking the time to present tonight. And thanks for everyone who's joining. And Dr. Baratt has a unique background. He's both a fellow of the American Veterinary Dental College and an equine specialist as well. I had a chance to see him in his use of the VetCat, which he explained tonight, and he'll actually demonstrate to you that he has a unique approach to use of 3D radiography. Thank you again, Dr. Baratt, for joining us tonight. It's an exciting presentation. We look forward to hearing your experience with the VetCat for the last several months since you had the device. We can see your screen. Here we go.
Great. Okay. So I would like to first acknowledge the great help I've gotten from David and his team at Xoran Technology, and also mention Jim Merritt, who is Dental Focus and was very helpful in helping me put together the purchase of this equipment. So the first thing that, I worried about was how darn expensive this was. And so it brought up all these questions for me. Do I really need it? Will it even pay for itself? Will it slow down my workflow? Am I even qualified to interpret the images? Shouldn't I just continue to refer my patients out for CT scans at the facilities near me that had helical CT? And then if I decide to get cone beam, which one do I pick? So first of all, I think, these are the really well-established indications for using computed tomography, fracture evaluation. It's really, really helpful. Maxillofacial tumor evaluations, really nice for looking at palatal defects. Those of you that are doing dentistry, recognize that intraoral radiography is really of little use in evaluating the palatal defects on the maxillary canine teeth. And it's really essentially useful for evaluating maxillofacial cysts. Does this screen sharing bar show up for you, David? Is there a way I should be getting rid of that?
Everything is fine. We can see your screen perfectly well.
Okay. All right. So, knowing that 3D evaluations really are not possible with intraoral dental radiographs, I think, that's really the gist of why you need cone beam CT is for these 3D evaluations. And now I find that I'm really at a loss if I don't have it, because I really depend on it for evaluation of all 3 rooted teeth. It's so helpful in evaluating brachycephalic dentition. It's really useful in looking at nasal diseases. It's surprising how much more sensitive it is for picking up apical pathology. And the only area where I'm not sure that of its value at this point for me is with endodontics. And I'll talk a little bit about that later. So will it slow you down if you incorporate it into your practice? Yeah, it will a little bit, but not very much. Essentially, in most instances, I can review the scan in the time it takes for the technician to perform the polishing, scaling and polishing of one side of the mouth. However, I would initially, if you're just getting into this, recommend that you practice evaluating the scans in the manner that I'm going to put forth in a few minutes when the animal is not anesthetized, because it will take you a while to develop speed. And in some cases, I don't even bother doing full mouth intraoral radiographs in addition to the cone beam CT. But you'll see in almost all my cases, I do both. The time-consuming process for me really is preparation of images for either the referring veterinarian or the owners. And this I usually do after the workday or on the weekends. So, initially I felt that, maybe I wasn't qualified to interpret cone beam CT. I did have a fair amount of experience looking at CT scans on horses and having to learn how to interpret them on my own. And I basically have been self-taught in terms of evaluating cone beam CT on small animals. But I think that like intraoral radiography, you will become perhaps better than the radiologist at interpretation of scans of the head. And you also have the intraoral radiographs to use as a kind of a training tool. So in comparing your interpretation of your radiographs and then looking for pathology that you see there in the cone beam scans, I think that allows for a pretty rapid learning curve. And there are a growing number of experienced colleagues and publications that you can look to for help. One thing that I found useful was this online resource called, I'm not sure how you pronounce that, but at any rate, for a pretty small subscription fee, you can use this interactive sort of website to go through the 3D multiplanar reconstructions and figure out the anatomy of, especially of areas that you're not that familiar with. And you can see that as you scroll through, it will identify different parts of the anatomy. And I found this useful for the ears, which I was really ignorant of. So maybe, you're presently referring out for helical CTs, and, why not just continue to do that? Well, here's a case that I looked at just a day or so ago. And this was the helical CT of the best unit that's in my area. And I specifically asked them to use the smallest slice size possible. And you can see up here that it was 93 slices for a study of the head. And you can see that the detail and the sharpness compared to a cat of similar size with my cone beam CT, it's significantly less clear. And this is, 494 4 slices, I think. And so here's the multiplanar reconstruction of the helical CT scan, and you can easily see the difference in the quality of the image. It is really a fantastic image with the cone beam CT. So then, you know, the next question is, which one of these units do you buy? There are multiple veterinary cone beam CTs available at this point. And, you know, for me, it was largely a function of the vet cat size and mobility being best suited for my existing dental operatory. I did also really appreciate the fact that they flew me out to visit their factory, and I could see firsthand the type of production and care and the quality of the work that was involved. I also relied on recommendations from colleagues, although to be honest, I haven't heard anybody who's bought another model or make of cone beam CT for veterinary use that has been unhappy with it. So this is my operatory, and you can see I have 2 tables, and I can just move the unit from one back to the other very easily. And this is the actual time for performing a scan, if you haven't seen this function yet. It happens to also work very well with the tables, the surgery tables that I use. So another reason not to just refer out for CT is that, you know, clients really hate, you know, anesthesia, as you all know. And so doing this one last time is really appreciated. They also appreciate the convenience of, you know, 1 procedure instead of 2, because most of them are traveling a significant distance. And in most cases, referral for CT will mean a significantly higher overall cost to the client. So they appreciate the savings. And I think also that a written report from the radiologist is likely not to be very helpful to you. So you're still going to have to do your own review of the scan, which means you have to get the facility that does the CT scan to send you the complete scan in DICOM format so that you can review it on your own computer. And finally, you know, referrals certainly adds unnecessary delay in treatment. So when I was first looking into this, it was pre-pandemic. And then all of a sudden, you know, I was ready to sign a contract in February, and the pandemic happened. So I was pretty damn nervous, and I negotiated a 3-month rental, you know, as to sort of try to figure out whether, you know, what the pandemic was going to mean for my practice and whether or not, you know, I could make the commitment to a lease purchase. So I made the decision to go ahead and have it delivered, got it in early March, and I decided to change my billing a bit. So I decided to charge $400 for dental imaging, which would include full mouth dental radiographs and the CT scan. And I was going to essentially do that for every case. And I was going to charge oral surgery out at $13.20 an hour. And so if I did a scan and an hour's worth of surgery, you know, my estimate for the procedure would be $17.20. So for me, an average day consists of 2 to 4 consultations and some rechecks in the morning. So I don't really get the first animal on the table till 9:30 or 10. And I usually do 1 procedure before lunch and 2 after lunch, sometimes 3 after lunch, but that usually makes it a pretty late day. And I do that 4 days a week for small animals. And then on the 5th day, I generally am doing horses. So here's what I put together, or had my bookkeeper put together for the period from March through October. And, I'm sorry, let me go back. Compared to what I had been charging previously, where I bundled oral surgery and radiology and billed at $12.70 an hour, just changing my billing resulted in an effective increase of about $450 per procedure that lasted an hour. And over the first 7 months, this totaled up to over $100,000 in net added income. So in terms of the workflow for me, we pre-medicate, catheterize, and pre-oxygenate while we're monitoring for the EKG, blood pressure, and PO2. And then we induce the animal and position for CT, start fluids, and put them on a ventilator, and finish hooking up all the monitoring equipment. The next step is to do the cone beam CT scan, and then, which takes a minute, and then we reposition for the dental procedure. And while my techs are finishing setting up for the procedure, on the VetCat, I send the study to Osirix, which is my cloud-based storage for imaging. You could also use the VetCat imaging storage, and then you don't have to do this step. So after doing the scan and sending it to my Osirix storage, I go ahead and do the full mouth intraoral radiographs and dental charting. And during that time, the transfer of the scan is occurring to Osirix. And then after doing the intraoral radiographs and charting, I'll have the technicians start the scaling and polishing. And it's generally during that time that I have enough time to evaluate the scan. And then I'll contact the owner and present the treatment plan and give them an estimate and do the procedure. So I thought, it might be helpful for a lot of you that are getting into this or have been doing it for a while even, to go through the evaluation that I do by sending it to Osirix and then evaluating it in the software called Horos. So the first step is to download the study from either Xoran Connect, which you can do here, or from Osirix. And then that is going to download into the those storage places onto the computer. And then you need to import the study into Horos. And Horos is a free open source DICOM viewing software. It's really a very sophisticated piece of software, and it's not that intuitive for the novice. They do have a subscription fee service called Horos Academy. I think it's only $100, and it's a sort of a webinar type thing that you can repeat as often as you want for a year. And it goes through all the functions more than you would ever want to know about on Horos. You can also purchase Osirix for a monthly fee, which is a slightly more sophisticated version of Horos. Now, while Horos was initially developed for use just on Macs, you can now do it with PCs as well, using Windows. And this is what the Horos website looks like, and you can just download Workstation from over the internet. There are other software DICOM viewers that are free, and this one is specifically available for Windows called Radiant. I don't think it's as nice a program, but it is functional and has the same basic capabilities. Okay, so we'll go through this in sort of a step-by-step fashion. So the first thing I'm going to do is open Horos and, open Asteris and download the DICOM images onto my computer. So I click on the download function in Asteris, and that will download them to my computer. And then I'm going to open Horos and import the files from my download files on my computer. And so here's where they are on the computer in my downloads file. So I go ahead and do that. And then it's going to ask me, Horos will ask me whether I want to copy the files or copy links. And I generally copy the links because if you copy the files, you're going to rapidly fill up your hard drive. Whereas if you copy the links, when you delete the downloads, then you eliminate the large file size that's taking up space on your computer. Okay, so then when you do that, that happens very quickly, and you're going to double click on this study, or you can double click up here on the one you just imported, and that will bring it up into a screen like this. And then my protocol is to go immediately up to the menu bar and click on 3D Viewer and choose 3D MPR. And it will pop up just like this. And you notice that the head is oriented upside down and nose pointing up here. So the next thing I do is go up and choose the rotate arrow, and like this, click on that, come down to the first panel and rotate that by dragging the cursor from left to right, and then go to the second panel, do the same thing and rotate that. And if you do this the same way every time, you know, it'll avoid confusion. And then once you have rotated the images, you can go up to the menu bar and click on Magnify to magnify them. Okay, and then you're ready to go. So here's the whole process again. Click on Rotate. Rotate each one. Click on Magnify. Now you'll notice that the three images are synced. So when you move the cursor in one, it moves it in all three. And you can grab the bar and rotate it so that you get a little 3D movie. And you can change the orientation. So if you notice when you, up here in the upper right, there's a sync zoom. That has to be highlighted in order for all of the images to move together, like I've showed you. So the first thing that I usually do is sort of scroll down to look at the palate. So here I've changed a little bit from the previous slide so that I can see the palate. And then you can see the roots of the palatal premolars and molars. And if you scroll back and forth in the third panel, you get a nice view of the palate. And now I've switched to thick slab, which is up in the upper panel. I'm sorry, let me go back. Up here, there's a item called thick slab. And when you click on that, you'll see that it goes from a single line. Here I'm changing that thick slab up there on the top. And that gives you a really nice view of the hard palate. Okay. So if you want to look at the mandibular arcade, you move the cursor down and line it up on the mandible. And I usually align the middle one up along the long axis. Here's looking at thick slab. So these are nice. This is a nice way to get a quick overview of the entire arcade. Okay, back to the regular view. Show you the difference. And, oops, sorry. Looking at the canine teeth. I thought there was a movie there, maybe not. Anyhow, the canine teeth are very nicely imaged by adjusting the cursors and changing so that you can get a view that looks very similar to your intraoral radiographs. So here's a case of a tumor in a cat, just showing you how the thick slab is useful. This is the thick slab, and I'll go back. This is regular. You can see it's easier to evaluate the tumor here than back here. And here's a 3D reconstruction. Brachycephalic dogs are, you know, you will wish you had had this cone beam CT years ago after you start doing the brachycephalics. And what I like to do on every case is this kind of a study of the 3 rooted teeth. So I line up the purple line here going across the palatal root and the buccal root, and then try to shift it around so that I also am catching the distal root. So here we've got all 3 roots viewed, the buccal two buccal roots and the palatal root. And this is with a little bit of thick slab. And this shows you how nice it is to evaluate it by just slowly rotating it. So this is a really sensitive way to evaluate the 3 rooted teeth.
And Dr. Baratt, there is a question here.
Sure.
Do you do this for each of the teeth, or do you focus on a problem area?
I really just use it on the maxillary 4th premolars and the maxillary molars, the 3 rooted teeth. Now, if you happen to have a 3 rooted, you know, 3rd premolar or 2nd premolar, it's nice there as well. But, and I will also use it on the premolars that are rotated. So for example, if you've got a small dog or a brachycephalic where the second and third premolars are rotated and packed in and crowded, it's very useful to use this technique to look at them. Instead of having superimposed roots, you can turn the, you can spin them so that you can see the roots individually.
Thank you.
You're welcome. And so let's see what we got here. Okay, so here's a movie showing first how I scroll back to look at the temporomandibular joints, and then do a little bit of a tipping so that you can fully evaluate each TMJ. You can do it this way as well. And here's a picture of evaluating a TMJ in a dog that had difficulty opening his mouth. And I don't really think there's a radiographic means using standard radiographs to really fully evaluate the TMJ like you can do with computed tomography. Here's a brachycephalic dog with a cystic structure here. And here's what it looks like on multiplanar reconstruction. This would be really hard to evaluate using any other radiographic technique. And this just shows you how by turning the axis on one, you can spin the image in the other two panels. This gives you a pretty darn good idea of what you're going to have to look at when you open this up surgically. And this is what this looks like. There's a function called a CLUT editor, and that allows you to change the appearance of the 3D reconstruction using this toolbar down here. So as I move this toolbar around, you can see it changes the appearance of the 3D reconstruction. This takes a little while to figure out. And I don't feel I have a really good handle on it yet, actually. And here's this dog with a large cyst, showing how you can adjust the transparency and density and color shadings. And you can manually turn it around or make movies.
So everyone, as Dr. Barrett is going through this demonstrations, if you have any questions, please post them within the Q&A so he can take questions you have. If you need to be unmuted, just raise your hand.
This is the cropping feature, which is helpful when you want to look at the palate. So you can get rid of the mandible, turn the head, and get a nice view of the palate. If you think you're going to do this, you have to leave some space between the endotracheal tube and the palate using some sponges. And again, like I said earlier, the cone beam CT is really great for evaluating fistulas. And sometimes what you think is a relatively small fistula, looking at in the dog's mouth turns out to be quite a big bony defect. Shown here as well in the 3D. Here's a case where there was bony swelling of the mandible and the intraoral radiographs. And this is what it looked like on CT. And here's with thick slab for comparison. And this is the 3D imaging.
We have another question regarding measurements.
Mm-hmm.
Do you perform measurements at this point, and how do you find points of references?
Okay, so up here there's a measuring tool, which is actually very accurate. You can measure the diameter of the root canal, the length of the canal. You can measure, put lines on the image and measure that way. You can measure volume, circumference. You can do polyhedrons. It's really quite, sophisticated software. I'll also mention that, I usually send all of these images to Cindy Bell, the oral pathologist, and she finds them very helpful. And I think, is starting to realize the significance of the cone beam CT imaging in terms of helping come to a good diagnosis on some of the weirder stuff. This one turned out to just be a weird case of alveolar expansion, bony expansion. Here's a case of dens invanginatus, which, I think you probably could make a diagnosis just using standard intraoral dental radiographs. This is what it looks like on CT, and you can really get a much better idea of the invaginating dentin here. This was a weird case, where the canine tooth is upside down and coming out through the dog's nose. Cone beam CT, was very helpful in trying to figure out, what my surgical approach was going to be to accomplish fixing this. You could see on the palate that there was no palatal defect here. And so I was going to try to get this out percutaneously and not establish an oral nasal fistula. And here's what it looked like post-op. And here's where I've cut away so I can see the frontal view. And I was able to keep, intact bone around most of this tooth during extracting it and only getting this area of defect nasally. I think, I really would not do fracture repairs at this point without getting a cone beam CT. It is so helpful. Here's a case that I saw recently, a little tiny dog. I think he weighed 7 pounds. Really complicated fracture. And I put on these first 2 plates and everything was lined up so nicely. I left it at that after closing soft tissue. He ended up actually, the owner never even called me. When it was time for the recheck, she said, "Oh yeah, I forgot to call you. He lost his right maxillary canine tooth." So if I go back here, this whole segment right here, I'm sorry. that whole segment, you know, which was kind of floating there, and I had no really easy way to stabilize it, and I wasn't sure it was vital to begin with. He actually sloughed that out and healed perfectly without ever getting any medical attention. I've played around a little bit with using contrast. You know, one of the big drawbacks of cone beam CT in comparison with helical CT is that you get better soft tissue resolution with helical CT. And so I thought, you know, maybe I could improve on that by using contrast. So I've been playing around a little bit doing that. I'm not sure I'm making great progress, but I'm sort of, you know, doing it by trial and error, and that's probably the slowest way you can do something. But anyhow, here's what this cat's CT looks like using a soft tissue window rather than a bone window. And there, in this case, there was enhancement of the mass, sort of an irregular enhancement of the mass using contrast. And you can see here in this image on the right that the jugular veins light up from the contrast. And you do get better imaging of lymph nodes as well using contrast. And I was playing around with this in 3D as well. And you can see here the jugular veins are picking up this type of contrast coloring, and the same coloring is present in the mass. So that's, you know, I got through that much faster than I thought I would. I was worried about having too much material to go over. It's, you know, since this is being recorded, you can play it back and go through those step-by-steps on your own, using your own computer and follow along. This is definitely something that takes some practice, but I think it's invaluable and really improves the level of your practice, and it will, I think, be very enjoyable for you in the long run. I'd be glad to take any questions.
Thank you very much, Dr. Baratt. This was a fantastic presentation, and your thoroughness shows through in every case and every step of the way. It's just fascinating how much you've enjoyed and learned and became an expert in using the this 3D device in a relatively short period of time. There's a question here about the contrast cases. Your timing in scanning. So if you, did you sort of time the scan in such a way that the blood vessels pick up the contrast the best, or do you have any recommendation on how quickly to image?
Well, I've tried doing it immediately. You know, as soon as I inject the contrast, start the scan. You know, there's a little bit of a lag there. I'm not sure how many seconds there are. I've also tried waiting 30 seconds. I'm not sure, you know, if waiting a minute or 3 minutes would make a difference. I haven't done the comparison yet. So right now is sort of a protocol. You know, I'm using the 30-minute lag. So I do a rapid injection. When I know I'm going to do the contrast, I'll use a larger catheter than I normally use so I can inject it quickly, because it is a pretty large volume for bigger dogs. Again, I don't know if anybody else has played around with this. I'd love to hear other people's experience, because again, I'm just playing with it and shooting in the dark, sort of.
Yeah, that's a good one. We've seen a few of your colleagues do relatively similar approaches that you're presenting today. And we're actually trying to formalize in particular the timing of scanning in such a way that we have the best enhanced image.
Mhm.
And it might actually vary a little bit depending on the size of the patient, but
Right.
we don't know that for sure yet. Yeah, it's interesting. You've shown some very interesting cases, and it is that fracture case that with reduction, you're showing a post-surgical scan. Do you one of the questions here? Do you tend to re-scan at the end of the procedure, or is it mostly for fractures, or do you do some scanning as well when you do tumor removal?
I generally rescan after the fracture repair. I've also been rescanning on occasion after endodontics, just to sort of get an idea of whether or not I got a good fill. If I see any defects in the fill, in the CT versus my post-op RADs, I've noticed that because the filling material is so radio opaque, I think it causes a bit of an artifact in the cone beam CT, making the canal look artifactually bigger than it actually is. Do you have any comments about that?
Yes, that's a good point. The gutta perca, the filler in the endodontic canal is so dense that there will be a slight amount of artifact on the image, and that's typical to all CTs actually, not only cone beam. It's actually a little better on cone beam CTs in general. And the best way to see the difference between a true void and that artifact is to look at the different images, different NPR views, because they will it'll be evident on another panel.
Right.
Also, if there's a defect a true defect in the fill, then it'll be very evident. It'll be quite significant.
Right, because as the image is rotated, you see the defect turn. So it stands right out. There's a defect.
You made an interesting comment also about, I see this couple questions here about temporomandibular joint. You're using that sort of same approach where you're rotating around the TMJ.
Mm-hmm. Right.
What are you looking for exactly when you do that?
Well, I haven't actually come across any degenerative joint disease in the TMJs of small animals since I've been doing this. But it certainly, if you had a fracture that involved the temporomandibular joint, that would be the approach that I would take to evaluate it. And that particular dog that couldn't open his mouth, it looked normal to me. We submitted serum for masseter muscle myositis serology. That came back negative. But the dog has been responding to prednisone treatment. So I'm not sure what the actual pathology was there, but it didn't appear to be, due to TMJ disease, at least to my eye.
Mm-hmm. Interesting. I have a question actually. You made a very interesting comment. You're sending the images to the pathologist as well. Is she using this for orientation of the biopsy, or is it just informing the pathologist of the type of disease like a radiologist would do?
I think she's used to looking at radiographs and finds that those are very helpful in addition to photographs of a lesion. And sometimes on these 3D reconstructions, she comments that, that was pretty interesting to see what, the bony changes were, or the lytic or proliferative changes were in 3D. So I think she finds it helpful.
Yeah, that makes sense. Well, I want to thank you again, Dr. Baratt, for this fantastic evening, very insightful presentation. I think we've all learned a lot. I'm going to just take a few seconds to make sure to maybe open the microphone. Aramidi, would you mind opening the unmuting and making sure that no one else has any questions? I believe we've answered them all.
Sure, I'm working on it. So if I
Thank
mute you, please know that you're allowed to talk. If you need to say something quicker before I get to you, just raise your hand and I will get that to you.
Thank you so much.
You're welcome. I believe I have Dr. Molly Angel, Dr. McTaggart in the room. If they wanted to share anything, they can unmute themselves. I unmuted them.
Thank you.
This image that's spinning here is a chinchilla.
Yes.
This is Sue
weighs
McTaggart.
about a pound.
Yeah, thanks a lot, Bob. I can't believe how fast you got onto this and using the 3D. I'm pretty impressed. But I feel the same way as Bob does. I don't know what I did without my cone beam, especially with the brachycephalics and fractures. So I want to thank everybody for making this available. I've enjoyed it and I learned stuff. Even though I have had my cone beam now for more than a year, I always got something to learn.
Thank you so much. Well, thank you all for attending this very interesting evening. Thank you again, Dr. Baratt. This
You're welcome.
video was recorded and it will be sent to the attendees very shortly in just a few days. Thank you. Thank you again. And we hope you enjoy the rest of the evening.
Thank you. Good night.
Thank you, Bob.
Thank you.